Okay, good afternoon. So today's lecture will be about the spinal cord and spinal nerves. I just want to remind you that now we are in block 2, and block 2 is dealing mainly with the nervous system and the endocrine system. Last time we dealt with an introduction about the nervous system and the histology of the nervous system or nervous tissue. So picking up from last time, we mentioned that the nervous system consists of a central nervous system and a peripheral nervous system. The central nervous system is the brain and the spinal cord, and the peripheral nervous system consists of the spinal nerves and the cranial nerves. So today it's a combination of spinal cord, which is central nervous system, and spinal nerves, the nerves that are attached to the spinal cord, which belong to the peripheral nervous system. Also, last time it was mentioned when we dealt with the injury of the nervous system and regeneration that nerves can regenerate if their axons are cut, but their cell bodies are preserved in the peripheral nervous system. But in the central nervous system, almost there is no regeneration. So that's why this means that the central nervous system has to be highly protected, because there is no way that if it is injured, there is no way that it can be repaired. Today, we're going to study some of these structures that protect the central nervous system represented in the spinal cord. And you can see here in this section, just I want to orient you. Here's the anterior part. You can see a vertebral body. This is a transverse section. And this one is a vertebral canal. And it contains the spinal cord surrounded by the meninges. Here, this is the region of the lamina. You remember the parts of the vertebra, there's a spinous process and there are laminae, and this is the body of the vertebra. And in between the body and the vertebral arch is the vertebral canal. So the first protective covering here comes from the vertebral column, the bone and the ligaments that connect between the bones. And then we have like a cushion of fat and connective tissue in this area. Of course, this is cleaned and dissected and the fat has been removed. And this is called the epidural space. It's outside the meninges, outside the first layer of meninges, which is called the dura mater. And then we have the meninges. The meninges here are called the spinal meninges, but these spinal meninges are the same as the cranial meninges, which are surround the brain. So they will continue with each other. There's a slight difference between them, but generally they are in 3 layers. So the outermost layer, which is the tough layer, is called the dura mater, and the term dura means tough. And then deep to it is another one, it's called the arachnoid mater. And then the pia mater, which is directly applied to the spinal cord. So that will be the dura, the region of the dura. Here will be the region of the arachnoid. That will be the pia. And you can see that there is a wide space between the arachnoid and the pia mater. This is called the subarachnoid space, and it is this space that contains the cerebrospinal fluid. So the fluid that surrounds the brain, that surrounds the spinal cord, is called cerebrospinal fluid. The term was mentioned last time when we mentioned the ependymal cells. These are the cells that produce the cerebrospinal fluid, and of course, having the cerebrospinal fluid around the central nervous system provides another protection for the central nervous system. Now let's go into more details of the meninges. As I mentioned that they are 3 layers. The outermost layer, which you can see it here in gray, this one is the dura mater. Please note that the dura mater, it is with 1 T, not matter. We deal with white matter and gray matter with TT. But when it comes to the dura, arachnoid, and pia, we say mater. Mater comes from matron. So these layers, matron like mother, so these layers, they surround the central nervous system like a mother surrounds the baby. That's why it was translated as such. In fact, this was directly translated from an Arabic term which describes these layers. So it's called al-Dimagh, which means that the mother of the brain, and was directly translated as the dura mater in this case. In many cultures, they use the father of, mother of, son of to describe certain things. Like, for example, even like in Scotch, they use like MacDonald, son of Donald, or in Russian, they use of, which like Antonov, son of Antony, or something like that. So these are used in different cultures, son of, mother of. So this is mother of the brain, dura mater. It's the outermost layer. It is consisting of tough, dense, irregular connective tissue. And then there's a very thin space, almost negligible, between it and the arachnoid. The arachnoid is this pinkish one, the arachnoid mater. It is directly applied to it. It's like it's on the other side. There's only a very thin layer of interstitial fluid in between them, and they are fused together. And the arachnoid means like spider. Arachne means spider. So it is consisting of loose connective tissue, loose with collagen fibers. And as I mentioned, it fuses with the inner surface of the dura mater. And deep to it is the cerebrospinal fluid. So you can see here that this layer, which is directly applied to the spinal cord or the brain, is the pia mater. And this is the arachnoid, and then the space in between them is called the subarachnoid space, which contains the cerebrospinal fluid. I will show that to you in this diagram. Probably it will be much clearer, maybe. Just to orient you about this picture, this is a picture taken from a dissection from the back. So the laminae has been removed with the spine. They have been taken away, and the dural sheath has been cut. And so you can see what is inside the dura. So if you look at this layer, this is in fact two layers. Sorry. If you look at this layer, this is in fact two. If you look at it from this side, then it is the dura. It is the tough part. If you look at it from the inside, then you can see it is smooth, glistening part. This is the arachnoid mater, but they are fused together. From one side it's dura, from the other side is the arachnoid mater. The pia mater is this grayish, highly vascular layer which surrounds the spinal cord, and you can see that there is a wide space in between them, which is the subarachnoid space, because it is between the arachnoid and the pia, so it is below the arachnoid, so it is the subarachnoid space, and it contains the cerebrospinal fluid. There is no space separating the pia from the central nervous system. It is directly applied to it. The other thing about the pia, which is shown here in this dissection, is that the pia has lateral extensions, like small teeth. So these are lateral extensions. We can see one of them here on either side of the spinal cord. But if we take the entire length of the spinal cord, then we will find that the pia mater has multiple of these denticulations, small teeth, called the denticulate ligament. And this denticulate ligament, obviously, it is anchoring the spinal cord. It is for the holding the spinal cord, anchoring it, because it's attached to the dura. Remember that this spinal cord is floating in fluid, so it needs something to anchor it from the side. So this is very important for anchoring the spinal cord. The denticulate ligament, it is nothing but a fold of pia mater extending between the pia and the arachnoid mater. Let's continue with the gross anatomy of the spinal cord. The spinal cord continues from the brain, the part of the brain that we are going to study next time, which is called the medulla oblongata. And this continuation is through a big foramen in the occipital bone. Remember the name of the foramen? We mentioned that before. Is the foramen magnum. So it is where the medulla oblongata of the brain continues with the spinal cord, and then the spinal cord continues through the vertebral canal. It is like a cylinder, but this cylinder is not uniform throughout its length. First of all, it's flattened a little bit anteroposteriorly. Second thing, it has like dilated and then narrowed and then dilated and then narrowed. So it has two dilations along its length. These dilations are called enlargements. One of them is located here in the cervical region, and it's called the cervical enlargement, and the other one in the lumbar region, and it's called the lumbar enlargement. Now, these enlargements indicate that there is more nervous tissue in these places. More nervous tissue means that there are more nerve cells, and these are required. The extra nerve cells are required for the for the nerve supply of the upper limb in the cervical enlargement, and for the lower limb in the lumbar enlargement. So there's more nervous tissue in the spinal cord to supply these structures. And you can see that there are 31 pairs of spinal nerves attached to the spinal cord. 31 pairs of spinal nerves. Now, it's obvious from this diagram that the spinal cord does not extend the entire length of the vertebral canal. So it starts at foramen magnum and ends here at the intervertebral disc between L1 and L2 vertebra. There's no more spinal cord below that. Below that, there are only spinal nerves, but the spinal cord itself stops. Look at the spinal nerves. The spinal nerves are named according to the regions of the vertebral column, and these are the same as the regions of the spinal cord. So we have 8 cervical nerves. There are 12 thoracic, 5 lumbar, 5 sacral, because the sacrum, although it is a single bone, but as we mentioned before, it is 5 fused sacral segments, and then there is 1 coccygeal nerve. And probably you might ask that, or you might wonder that these numbers do not necessarily conform with the number of vertebrae. If you remember, how many cervical vertebrae do we have? 7. So we have 7 cervical vertebrae, yet we have 8 cervical nerves. But in the thoracic, we have 12 thoracic vertebrae, we have 5 lumbar vertebrae. Let's say we have 5 sacral, although it's 1, but 5 vertebrae fused, and we have 4 coccygeal vertebrae, but fused together as a single bone. So the number of the spinal nerves does not always reflect the number of the vertebrae. And each of these spinal nerves is a mixture of sensory and motor fibers. I will come to this point in a moment. Also here, I want you to notice in this diagram here, this is from a lateral view, you can see that the spinal cord terminates at this location. In fact, during embryological development, the spinal cord occupies the entire length of the vertebral canal. And the spinal nerves, they arise horizontally from it and leave in between the corresponding vertebrae. But then what happens is that the spinal cord becomes shorter than the vertebral canal. Not because it becomes shorter, both of them are growing. But the vertebral canal, the bone, overgrows the nerves. So there is rapid growth of bone, but there is less growth of nerves. So the spinal cord becomes shorter and shorter. So at birth, for example, the spinal cord reaches the level of L3, L4, but in the adult, it reaches the level of L1, L2 vertebra, and that's it. It stops at this point. Now, look at this dissection. This is a dissection of the posterior, again, aspect of the vertebral column, including the sacrum. That will be the region of the sacrum here. Okay, so it includes the sacrum as well. And you can see here that here is the spinal cord. Okay, so the spinal cord, when it ends at the level of L1, L2, it gradually tapers down into a cone-shaped structure, cone. So it's called the conus medullaris. That is the end of the spinal cord. The most caudal end of the spinal cord is the conus medullaris. Remember that the spinal cord was covered by pia mater directly applied to it. So when the spinal cord terminates, the pia mater, which is just a fibrous tissue, it continues down. Okay, remember that the spinal cord occupied the entire length of the vertebral canal before. So the pia mater continues down as a thread, as a terminal thread, as a terminal filament called filum terminale. And this filum terminale is attached to the coccyx, and it is another support, another anchor for the spinal cord. Remember, we have lateral anchors, which are represented by denticulate ligament of pia mater. This one, the filum terminale, it looks like a nerve, but it's not a nerve, it's connective tissue, a thread of connective tissue that anchors the spinal cord and connects it to the coccyx. You can see it here among the other nerves, among the roots of the nerves. You can see it here, like it is a little bit grayish in color, lighter in color at this location. Okay, it's very light, and this is you can differentiate it from the nearby nerves. So it's called the filum terminale. So this level here is level of L1, L2 vertebra, and below L1, L2 we don't have the spinal cord. What do we have is the roots of the spinal nerves. So there's this one, let's say for L3, and then L4, and then L5, S1, S2, S3, S4. So these roots of the spinal nerve continue down until they reach their corresponding foramina, from which they should leave the vertebral canal and will leave. So we will get a bundle, a tuft of these roots of spinal nerves below the level of L1, L2, called the cauda equina. It looks like the horse tail. There's no spinal cord. We have only roots of spinal nerves plus the filum terminale, and this is called the horse tail, the cauda equina. Cauda means tail, caudal, to the tail side, and equina like from equestrian, something related to horse. So cauda equina. These are the roots of the spinal nerves below L1, spinal nerve. So L2, L3, L4, L5, all of them, until the first coccygeal nerve, they will constitute the cauda equina together with the filum terminale. And you can expect here that these roots, they are floating in cerebrospinal fluid. The cerebrospinal fluid, or the subarachnoid space, ends at this level. It ends at the level of S2 segment, second sacral segment. And this sacral segment is indicated on the surface of the body by the two dimples that are present just above the buttock. There are two dimples. That is the level of S2, and that is the level of termination of the subarachnoid space, not the spinal cord. The spinal cord terminates here at the level of L1, L2. This means that between this level, lower border of L1, until the level of S2, the vertebral canal has only roots of spinal nerves floating in fluids. So if we want to have a sample of this cerebrospinal fluid, let's say, what we call it lumbar puncture, it should be done in this region. You don't want your needle to pass into the spinal cord, so you should avoid the spinal cord. You go below the spinal cord, and again, you want your needle to tap fluid, so there must be fluid here. So usually what they do is like this. The patient is on the lateral side, flexed at the lumbar region. This is the needle. The needle will be passed through the skin, and then in between the spinous process of vertebrae. So this is vertebra L4 vertebra. They use the spinous process of L4 as an indicator, L4 vertebra. Either they go above L4 or like here, or they can go below L4. And then they pass through the ligament in between the spinous process, epidural space, dura mater, arachnoid mater, and then in the subarachnoid space. And they can tap fluid for laboratory examination, they can inject antibiotics, they can inject radio-opaque material in radiography, they can inject anesthetics to produce spinal anesthesia and the anesthesia of the lower part of the body, because all these nerves below the level of L1 will become blocked if they inject the anesthesia at this location. Now the question here is, how do they identify the spine of L4? Do they start counting from here? C1, 2, 3, 4, 5, 6, 7, and then T1, 2, 3, 4, 5. What do they do? There's a plane which is called the supracristal plane. Remember the iliac crest, hip bone, which has two iliac crests, the place where you take a bone marrow biopsy. These crests, there's a crest of bone here, crest of bone there, okay? So from the back, the supracristal plane, fortunately, intersects in the midline with the spine of L4 vertebra. So they either go above this or below that. And in this way, they are going to avoid hitting the spinal cord. But there is still a possibility that they are going to hit a root of a nerve. But do you think that they can penetrate that nerve if they hit it? No? Why? If they hit the nerve, could they penetrate the nerve if you hit it by the needle? Exactly. The nerve will move away because it is suspended in fluid. So once you touch it, it moves away. So it's not like the spinal cord, a very thick cylinder. It's like a thread, and it will move away. It is suspended by fluid, the fluid that you want to tap. This is a cross-section of the spinal cord, and you can see that the spinal cord consists of gray matter and white matter. Okay, not matter, okay? And it might be confusing at the beginning because the gray matter looks whiter or lighter than the white matter, and the reason for that is that the stain that is used here is specific for myelin. So that's why it stains myelin. So myelin appears darker, and myelin and myelinated nerves constitute the white matter, while the gray matter of the brain or the spinal cord, they are formed, as I mentioned last time, of the nerve cell bodies, of the dendrites, unmyelinated axons, neuroglial cells, but not myelinated axons. The myelinated axons will form the white matter, but they appear dark here because they are myelinated, because the stain stains the myelin sheath. And you can see that the gray matter, therefore, has a capital H shape with described with two horns, a posterior or dorsal horn and an anterior or ventral horn. Here in the nervous system, usually we use more of dorsal and ventral more than anterior and posterior, but you can use either of them. Okay, anterior is ventral and posterior is dorsal. Remember the first lecture we had in block 1. Okay, and in some regions of the spinal cord, like this one, we have a small lateral horn. So this is not always present in all regions of the spinal cord, but is present mainly in the thoracic and upper lumbar regions. The dorsal horn of gray matter contains nerve cell bodies that are mainly sensory, while the ventral horn contains nerve cell bodies that are mainly motor, and the lateral horn contains autonomic nerve cell bodies belonging to the autonomic nervous system. Okay? In the center here, there's a very small, tiny, rounded central canal. This central canal contains cerebrospinal fluid. It is a continuation downward of the ventricular system of the brain, in which cerebrospinal fluid is produced by the lining ependymal cells. And then the cerebrospinal fluid will escape the ventricular system through certain openings. We are going to talk about this by the end of the week, and we'll go to the subarachnoid space. So it circulates actually. It starts inside the brain, it is secreted inside the brain, and then goes around the brain and the spinal cord to return back to the blood. So this central canal here, the small tiny canal, contains cerebrospinal fluid, and of course most of the cerebrospinal fluid will be present here around the brain, around the spinal cord, in the subarachnoid space. Now the white matter is divided into 3 columns. We have, this is the posterior column on one side, this is the posterior column on the other side, and then we have anterior column and lateral column. So we have posterior, lateral, and anterior columns of white matter. White matter means myelinated axons. These axons, they can be either ascending or they are descending. So descending means that their cell bodies are located here in the brain, means that they are bringing orders from the brain, means that they are motor. The ascending means that they have their cell bodies in the peripheral parts. It means that they are taking sensations from the peripheral part of the body and taking it up to the brain. So they are sensory. And these fibers, these axons, they usually, the ascending axons or the descending axons, they bundle together and they form what we call tracts. Like fasciculi of axons, they form tracts. Like for example here, let's deal with this one as an example. It's called corticospinal tract. As the name indicates, cortico means cerebral cortex. Spinal means spinal cord. So this tract starts from in cell bodies in the cortex to the spinal cord, and usually it ends at cell bodies which are located in the anterior horn. It is motor. It gives orders to anterior horn cells, and then the anterior horn cells, they send their axons to the spinal nerve to supply, for example, a muscle and cause a contraction of muscle. They are motor fibers. And usually the axons that have a common origin, a common destination, and serve a specific function, they usually bundle together in the form of tracts. So we have these names of tracts, as you can see them as an example, like the corticospinal tract. These are present in columns. Column consists of more than one tract. We're going to talk about these tracts later on when we deal with the motor and sensory system. Of course, we're going to talk about examples. We're not going to deal with all these tracts, but this is just an introduction of what does it mean, a tract. It's like a nerve in the peripheral nervous system. Bundles of axons, okay? But these have a specific origin and they end in a specific destination. The example, as I mentioned, the corticospinal tract arises from the cerebral cortex to anterior horn cells of the spinal cord, and then these anterior horn cells are motor neurons, and they are going to provide axons that will go to the spinal nerve. So how is the spinal nerve formed? You can see it here. Look at these anterior horn cells. The anterior horn, remember I just mentioned before that the anterior is motor. Okay, so these neurons which are present in the anterior horn, they are motor neurons. These are motor neurons. They send their axons, and the axons will form what we call a root, a ventral or anterior root of the spinal nerve. This is motor or efferent root of the nerve. Roots. It's like a tree. So there are roots. Actually, we have two roots. The other root here is posterior or dorsal roots, and this is the sensory root. And you can see that the root is distended at this location by a ganglion. A ganglion, as I mentioned last time, is a collection of nerve cell bodies outside the central nervous system. And you can see here the distension is produced by one of these cell bodies as a representative. This is not the only cell body. The blue one, the rounded one, means cell body. So this cell body has processes. As you can see, it has a process here that immediately divides into a central and a peripheral process. This is a sensory neuron present in the dorsal root ganglion, which is located in the dorsal root of the spinal nerve. What type of neuron is this, structurally speaking? Functionally, it is sensory. But what type of neuron is this one in the dorsal root ganglion? We mentioned that last time. I just want to remind you. What are the structural classification of neurons? There are multipolar, bipolar, and pseudo-unipolar. So this is a pseudo-unipolar neuron. One process that immediately divides, like the letter T, capital letter T, into two processes. So we have two roots. They unite together and form the nerve. So the nerve consists of axons that are motor and sensory. And when the nerve is going to branch later on, the branches of the nerve are mixed. The roots are not mixed. Be careful. The roots are not mixed. They are either sensory or motor. When they form the trunk of the tree, when they form the nerve, it will become, the nerve is mixed. And when the trunk divides into branches like in the tree, the branches are mixed. So here are the branches. Look at this section, a transverse section again. You can see the spinal cord in the midline with the capital H, and this is a dorsal root, a ventral root, forming a spinal nerve. The spinal nerve appears or arises from the intervertebral foramen and divides into a posterior, we call it ramus, and an anterior primary ramus. So these rami, whether posterior or anterior primary rami, they are mixed. They contain sensory and motor fibers. Look at the posterior ramus. It is much thinner than the anterior ramus because it supplies only a narrow area at the center of the back of skin, so sensory because it has sensory fibers, and it also supplies these muscles, the erector spinae muscles. Remember we mentioned that they are the muscles that we eat them when we order rib eye or sirloin steak. So these are the muscles that are supplied by the posterior root of the spinal nerve, while the ventral root or the anterior root is much thicker than the posterior root because it's going to supply all the structures that are present in the lateral and anterior part of the trunk, as well as the limbs, which are derivatives of the trunk. So they are supplied by anterior primary rami of spinal nerves. Again, I want to emphasize this point. The roots of the nerve are either motor or sensory, but when they form the nerve is mixed, and so the branches of the nerve are also mixed. Now, what is a plexus? A plexus is a network. It's a network of nerves, network of adjacent spinal nerves. An example of a plexus is the brachial plexus, which is the nerve plexus that supplies the upper limb. You can see here what happens in the plexus is that axons, they exchange in between the spinal nerves. There is exchange of axons. So you can see here in the plexus like C5 and C6, for example, C5 nerve and C6 nerve, they are joining here, and then they are dividing, and then joining, and then dividing. So these branches of the plexus, which have nerves that have names, not numbers, names, like the radial nerve, median nerve, ulnar nerve. Remember the median nerve? We mentioned that nerve that passes deep to the flexor retinaculum and is caught in carpal tunnel syndrome. This is a nerve, a branch of a plexus. If we want to follow it back to its root value, we will find that its root value is from C5 to T1. All these contribute to the formation of this nerve. It's not only one spinal nerve. Let me give you another example. Look at this nerve. We haven't mentioned it before, called the long thoracic nerve. I'm mentioning as an example. You don't need to memorize it. The long thoracic nerve. Just to remind you, this long thoracic nerve supplies the muscle that is used for protraction of the scapula, the serratus anterior muscle. So this nerve has a name, but as you can see, look at the roots of the nerve. It is from C5, 6, and 7. So all these nerves, adjacent nerves, they will provide axons that will contribute to the formation of a single nerve. So that is the plexus. It is where adjacent spinal nerves join together and exchange fibers. We have multiple of these plexuses. We have a plexus in the cervical region. We have for the head and neck. We have the brachial plexus for the upper limb. We have the lumbar plexus for the lower trunk and lower limb, and the sacral plexus for the lower limb and the perineum. And here, as you can see, in the thoracic region, the thoracic spinal nerves, they do not form plexuses. So they only supply segmentally. They supply the skin, and muscles are supplied segmentally. There is no mixture. There is no exchange of fibers between them. And the plexuses are formed by anterior primary rami of spinal nerves, not posterior. The posterior primary rami are for the erector spinae muscles and a very narrow area of skin of the back. This is the brachial plexus, and you can see here the branches of the plexus. I just mentioned the median nerve. The median nerve is a branch of the brachial plexus. We cannot attribute it to one spinal nerve because multiple spinal nerves contribute to its formation. Okay? This is how the nerve is formed. It is formed of multiple axons. So what is the axon? The axon is a nerve fiber. So the nerve fiber is an axon The axon, as you know, mentioned previously, is surrounded by myelin sheath, or just by Schwann cell, not necessarily myelin sheath. And these axons will bundle together and will form fascicles. Okay, so nerve fiber will form fascicles, multiple fascicles. Like this is a fascicle, this is another fascicle. You can see this is another fascicle. So multiple fascicles will form a nerve. It is exactly the same as the concept of a muscle with fascicles with muscle fibers. Okay, so muscle fibers, they form fascicles, and the fascicles will form the entire muscle. The muscle fiber is the nerve cell, and all these structures, again, is the same concept like in muscle, and probably I mentioned that when we dealt with the muscle. They are covered by connective tissue. So there is a connective tissue covering each axon, each nerve fiber, like there is connective tissue covering each muscle cell. And this covers the axon, whether it is myelinated or unmyelinated. It is covered by this connective tissue, which again has the same name. But here the difference is that we use neurium, so endoneurium instead of endomysium. And then the fascicle is surrounded by a perineurium instead of a perimysium. And then the entire nerve is surrounded by epineurium instead of epimysium of muscle. If you go back to the lecture on the histology of muscle, you will find the same prefixes, but the only change is that we replace mysium with neurium. Now, this is another concept here. It's about dermatomes and myotomes. The word dermatome, derm means skin, and tome means piece. I mean, cut or piece of skin. So dermatome is the piece of skin that is supplied by one spinal nerve. As you can see here, all these are dermatomes, T1, T2, T3, T4, and they are easily drawn or easily traced in the trunk because there is no plexuses. But when it comes to the lower limb or when it comes to the upper limb, because of the presence of the plexuses, they will become a little bit complicated. You don't need to memorize these maps, okay? But you should keep in mind that knowledge of these dermatomes is so important for the diagnosis of neurological diseases because they can localize the level of the lesion. Where is the disease? Where the disease has started, or what is the level of transection of the spinal cord? Because at certain levels of transection, the sensation and motor activity will be lost below that level of transection in the spinal cord. A myotome is a group of muscles that are supplied by one spinal nerve. Let's build on the dermatomes here again. So, as I said, that knowledge about dermatomes is important to localize the lesions. Like, look at this picture here. This is a picture of a patient who suffered herpes zoster. Herpes zoster is a viral infection. The common name is shingles. So it's a viral infection that affects the dorsal root ganglia. Remember? This is the dorsal root ganglia. And these vesicles and itching and pain will be distributed along the piece of skin, the dermatome, that is supplied by that spinal nerve. So it can give you an idea where is the location of the lesion. And here, if you look at this dermatome, it is the dermatome around the nipple. Compare it with the dermatome map, then we are sure that it is at T5. This is T5 spinal nerve that is affected, okay? Another thing here, like if T5 is cut, okay? If T5 is cut, then there will be loss of skin sensation. There must be a loss of skin sensation, but in fact, in reality, this does not happen because if we look at the diagram again, look at the right side of this diagram. Look at T5, right side, on the right side, and compare it with the left side. You will see that the same area on the left side is overlapped by T4 and T6. So if T5 is affected, then the neighboring dermatomes will compensate because they overlap the area. So if only one spinal nerve is injured, then there will be no loss of skin sensation if there is only one injured, because the neighboring dermatomes can compensate for that. The other concept that is also important to consider, but you don't need again to memorize the map, although this is required to be memorized by a neurologist, let's say. So there are dermatomes, which are the areas that are supplied by a single spinal nerve, and there are cutaneous fields. These are the areas supplied by named nerves, not numbered nerves. So in that case, like for example, this is the area that is supplied by the radial nerve, or this is the area that is supplied by the median nerve. So if there is injury of a peripheral nerve, then the area of loss of sensation will give an indication that the injury is peripheral, not central. Because if it is central, because if it is affecting the root of the nerve, what they call it radiculopathy, then it is the dermatome that is going to be affected. So knowledge of both dermatomes and cutaneous fields of sensation is important to give you an idea, or to give the specialist an idea about the localization of the nerve disease. Last point here is about reflexes. And reflex is a fast, involuntary, unplanned sequence of actions that occur in response to a particular stimulus to promote homeostasis. In easy words, this is a reflex. We are tapping on the patellar tendon. Remember the patellar tendon in the front of the knee joint? And this will cause reflex contraction, reflex extension of the knee because of contraction of the quadriceps femoris muscle. So this is a reflex. You tap, you stimulate a sensory receptor and will result in a motor action. Okay, this is what we call a knee jerk. Some of the reflexes are somatic, involve skeletal muscles like this one. This is a somatic reflex. And some of them are visceral reflexes. For example, let's say when stimulating something result in contraction of cardiac muscle or smooth muscle or secretion of a gland. Like for example, we have the pupillary light reflex. Probably you have done that on yourself. If not, do it today. Like if you shine a light on your pupil, you can look at the mirror, shine light at your pupil, and you will see that your pupil constricts. This is called the pupillary light reflex. This is a visceral or autonomic reflex. Some reflexes we are inborn with them. Okay, like for example, when you touch a hot surface, you will move your hand away from it even before you feel that it's hot. You probably will feel the hot surface after 1 or 2 milliseconds maybe, but this is an inborn reflex, and some of the reflexes we learn them. They are acquired reflexes. Like whenever there is a danger, you're going to slam the brakes of the car. This is to give you an idea about the reflex arc. I will come back to this reflex arc when we deal with the sensory receptors, just to give you a brief idea at the moment. You can see this is we call it the neurological hammer. You tap on the tendon, on the patellar ligament, and this will give an indication to the muscle that the muscle is stretched. So in the muscle, there are receptors. We have not studied them in the histology of muscle. We are going to study them with the sensory receptors. This is a receptor. So this receptor will feel as if the muscle is stretched, although the muscle is not stretched. Normally, if the muscle is stretched, it will give indication to the spinal cord to contract the muscle. Okay? So what happens here is that the muscle is not stretching. We are tapping on the ligamentum patelli, giving indication that the muscle is stretching. And so we have a receptor to start the arc, and then we have a sensory neuron, which is located in the dorsal root ganglion, sensory neuron. And then this will take us to a center, an integrating center, which is the spinal cord. The integrating center will send impulses to the motor neuron, which is located in the anterior horn cells. The motor neuron will give impulse to the muscle, which is the effector, to contract. So these are the elements, these are the parts that or components that constitute a reflex arc. Of course, this integrating center. Why do we call it integrating? Because if we go to the details here, we will find that there are excitatory impulses are given to the agonist muscle, while inhibitory impulses are given to the antagonist muscle. Remember, agonists and antagonists? So the antagonist here for the quadriceps femoris are the hamstring muscle.